Welcome back to Pharmacology, where we've looked in depth at pharmacodynamics, how the drug works on the body. We saw that we have agonist drugs, partial agonist drugs, and then there were those that were antagonistic. We looked at different types of antagonists. They might be blocking an enzyme from being able to access its normal substrate. These antagonists might be directly blocking at the receptor, stopping the agonist from binding, or that antagonist might be binding at a completely different site. They're still a functional antagonist, but they're non-competitive. They don't compete for the active site, and we looked at ways of doing tests on the efficacy of agonists in the presence of antagonist, and if adding more of the agonist or the endogenous substance overcomes the antagonism, well, clearly they were competitive. They were competing for the same active site. But if adding more if adding more of the natural endogenous substance didn't overcome the antagonism, then it was probably this functional antagonism, a non-competitive antagonism at another site. We're now actually going to look at a related concept, and that's the concept of pharmacokinetics. We're still really interested at seeing how much of our target drug can get to the site, that receptor, that enzyme, or other protein in the body, but we saw that there are other chemicals other than proteins that might also be the target for drugs. But to get there, that drug has to go through a pharmaceutical phase. It has to break down from the formulation in which it was taken by whatever route. So we'll look at some of the routes of administration. We'll look at some pharmacokinetic parameters. That's how the body acts on the drug to then deliver it to its site of action, where that drug will then have its pharmacodynamics. So whatever formulation of drug is used, it will be administered by that route, and in that formulation. For Western pharmaceutical drugs, it could be an enteral route, which will basically be the per oral route, but there are some other parenteral routes, that is not via the gastrointestinal tract, generally means by injection. So we'll look at subcutaneous route of administration, intramuscular, intrathecal, which will go directly into the theca, the hard coverings around the spinal cord, so as then to introduce that drug to the cerebrospinal fluid. It might be the inhalational route or the topical route. The one parenteral route not given there, the intravenous route, another route of administration, but it will deliver drug directly to the systemic circulation. And here with these other routes, we are looking at how there has to be some further absorption, then leading to that substance entering the systemic circulation. In the systemic circulation, we're going to have a look at a whole variety of factors that determine how that drug is distributed. We'll see that it doesn't move in the systemic circulation as free drug. It's often protein bound, but as we're going to see, that's a reversible binding. From that systemic circulation, or in the case of an intrathecal route of administration, that local circulation around the spinal cord, eventually that drug will move from the blood vessels into the target site, but it's going to also be moving into a whole variety of other tissues in the body, so it will distribute to more than just one compartment. That will be key. One of those compartments might be the liver, or it might be there in the gastrointestinal tract itself if it was per oral route, where metabolism of that drug will start to occur. Once metabolized, the aim of metabolism, as we'll see, will be to make drugs less lipid soluble or perhaps more water soluble. This will help with excretion of that substance. So the four main pharmacokinetic parameters that you have to know and be able to apply to a variety of Western pharmacy drugs, and then to apply those same concepts in your own modalities. Pharmacokinetics is the administration, distribution, metabolism, and ultimate excretion or elimination of that drug. So after administration, absorption, then distribution to many compartments, including the systemic circulation, from that systemic circulation to the target site, but also to other tissues where metabolism and ultimately excretion will occur. Pharmacokinetics. So the routes of administration we saw were divided into enteral and parenteral. There are a whole variety of other routes of administration that don't neatly fit into those two categories. Enteral will basically be the oral route or the rectal route of administration. So via the gastrointestinal tract, it can include buccal administration of drugs and sublingual administration of drugs, but we'll see that here the speed at which they then enter the systemic circulation is completely different when it's delivered by the buccal or the sublingual route as when it is then orally taken and is absorbed by the digestive tract. So the parenteral route, other than the enteral route, other than by the gastrointestinal tract, as you'll see, does basically equate to being a route of administration by injection. We talked about a few of these. The intravenous route delivering directly to the systemic circulation. The others ejecting into other tissues, subcutaneous tissue, which will be very fat-rich but also capillary-rich. Intramuscular tissue, which will, of course, contain a lot of muscular fibres, very thick cells, and surrounding them a rich capillary network, and that's actually where you're trying to get the drug to absorb. Intrathecal, we said, was introducing a drug into the fluid bathing the spinal cord, so we're going through the covering, intrathecal. In a similar way, the epidural route will bathe the dura mater, and the material, this drug substance, will then be absorbed and have its effect in the CNS. So an epidural route of administration. Then last of all the last parenteral route, intradermal, where we're introducing a drug across the skin. Intra, within, and in this case within the skin. So the other routes that don't fit neatly into that enteral or parenteral classification will include the inhalational route, just direct topical dermal application of a drug. So not intradermal, where you wish the drug to be absorbed into the systemic circulation after being applied to the skin. This is something that will act locally at the skin, dermal. So there will be very little systemic absorption, one would hope. Similarly with ocular, nasal, otological and urogenital, they are all topical routes of administration where you are hoping there will actually be very little absorption into the systemic circulation. Now with each of these routes of administration, you're going to do some research and compare them. Then you'll contrast them. So that will mean you'll be looking for pros and cons with administration of these drugs via each of these routes, to then apply that information to your own modalities, where the commonest route of administration, once again, will be the oral route, or perhaps in complementary medicine, some of these topical other routes of administration. With oral administration of the drug, that's per oral, the drug has to go through a pharmaceutical phase, first of all, where it has to undergo dissolution. So basically, dissolving. If it was a tablet, it will have to break down from that solid form into a particulate dispersed form so that it can be absorbed. In this way, the active ingredient will then actually be able to cross membranes and be transported into the systemic circulation, where we will say it has been absorbed. Or, should we qualify more generally to say, into a circulation, in the case of, say, intrathecal or epidural administration, where we're trying to get it to absorb into a more local circulation and then to the site of action. So all of that stuff that you studied in chemistry on the diffusion rate of substances will come into play here when we look at how fast and how readily that drug is absorbed across the membranes of the body. Then consider a different route of administration, still enteral, but this time the sublingual route of administration. Here what you're actually trying to do is to get the substance to move from the oral cavity directly into the rich capillary network, the arterioles and the venules underneath the tongue, so sublingual. From there, those substances will go into the superior vena cava and there to the heart. And from the heart, they'll then enter the systemic circulation. You'll then appreciate that by reaching the organs of the body, the liver, where we'll see some biotransformation will happen on that substance, and the tissues of the body, where one of those tissues, perhaps one of the organs, maybe the liver itself, or one of those tissues will actually contain the proteins that are the target for that drug. We'll see that the kidney can also do some biotransformation reactions on that drug, and of course the kidney will be the major route of excretion, but we'll see some drugs are excreted in bile, where the liver then will be the important organ of excretion. But by taking this drug by the sublingual route, we have bypassed the portal circulation by which glucose and amino acids are sent to the liver after they are absorbed through the gastrointestinal tract. Most other drugs that are taken per oral and swallowed and absorbed through the gastrointestinal tract will likewise make their way into the portal circulation and to the liver. When that happens, when a drug is absorbed by an enteral route where absorption actually happens from the gastrointestinal tract, there will always be high first-pass metabolism as that drug first passes from the portal circulation and into the liver, where the majority of biotransformation enzymes are found. So there'll be a large amount of clearance of that drug. Won't even reach the blood, the systemic circulation. It'll be cleared from that portal circulation. Whether that drug then is eliminated in the kidney or the bile through feces or some other route of elimination, large amounts of altered drug and therefore oftentimes less biologically active drug will be cleared from the body. So this first pass metabolism is a key concept, showing that with the oral route, high first pass metabolism, large amounts of that drug going through the portal circulation to the liver and then being biotransformed and cleared from the body. But other routes of administration, we've used the sublingual route as an example, showing how you can bypass the portal circulation, bypass the liver, and bypass a lot of that biotransformation. We are showing you that there, through the systemic circulation, will still be some metabolism of that substance in the liver and other organs, but it will be much less. That is the key concept. So that would be a low first pass metabolism if it reached a systemic circulation first. So in a similar way, you'll look at other routes. We've chosen here the inhalational route, so pulmonary absorption. Here you will get rapid absorption and into the systemic circulation, but then there will be other disadvantages to that route. The drug will actually have to be gaseous, or it will have to, if it's liquid, will need to be able to volatilize very easily, that is, turn into a vapor or turn into a mist. So some drugs don't turn into volatile vapors or gases, but they can be turned into small droplets. So they can be aerosolized and taken by the inhalational route, but not all medications can be taken by that route. So that will be a serious limitation for Western pharmacy drugs, and as you'll see also in your modalities. But we will get good absorption across that pulmonary epithelium, the mucous membranes and other structures in the respiratory tract being quite thin and enabling rapid access. However, one problem with the inhalational route, it's very hard to regulate the dose accurately, and we'll see that when we get to the last session and look at drugs working in asthma, where they're often taken by this inhalational route. So the topical route of administration, another one that will get you to consider because it will be used quite commonly for complementary medicines and is a common topical site of application of Western pharmacy preparations so as to avoid a lot of adverse effects. it's using this idea of avoiding first-pass metabolism. It doesn't even go into the portal circulation, doesn't even go into the systemic circulation largely. So it will have fewer adverse effects, and there will be much less breakdown, biotransformation, and elimination of that substance. Way less first-pass metabolism. But once again, as we saw with the pulmonary route of administration, there's very few drugs then that might lend themselves to that topical administration. For the intact skin to be absorbed through, that formulation would have to have lipid substances, and the drug itself would have to have some lipid solubility. You've also got to consider how much surface area over which that substance would need to be applied for it to be absorbed. There can be differences in the absorption rate through the skin where there's little subcutaneous fat, so perhaps in elderly clients or other clients with very dry skin or disorders in the skin. So you can enhance absorption by using an oil or an emulsification if it was still a rather water-soluble drug, and then trying to rub it into the skin. If it's working topically, it could have good efficacy, but that can be variable and unpredictable for a lot of substances where it's actually in the deeper tissues of the skin that it has to have its actions. A good example to show variable efficacy is if you look at the advertisements on TV which talk about antifungal preparations and how long it can take for them to actually have an effect. So even though topical administration is meant to avoid systemic absorption and thereby avoid a whole range of adverse effects, we'll see when we look at corticosteroids that are applied topically through the skin that there are still sufficient levels absorbed that if that was a chronic application to the skin, then there could be chronic long-term adverse effects from that topical administration.